Immediately near of it, from external layer of dura, you form the flap, which is approximately equal or little more to the size of this defect. Base of this flap should look to the side of defect. Then you disconnect it, external and internal layers. You turn this flap to the defect, and you apply interrupted sutures between the margins of sinus and margins of this flap. But what can I do if the defect is huge, big, and I don't have enough material to close it? Unfortunately, it can be happen. And the single method which I can suggest you in this case, it is ligation of the sinus. It means you will take the needle with the thread. Usually it is big curved needles, and you will provide it this needle with the thread through the wall of the not sinus but process, inside of which we have the sinus. For example, this is falx cerebri. Inside of it upwards we have superior sagittal sinus. What should I do? I must provide it the needle with the thread in such a way, outside of the sinus but inside of the process. Distance between sinus wall and between your piercing place will be not less than 0.5 centimeters, sometimes more. Why? It is so-called protectional belt. If you will do piercing immediately near the wall of the sinus, during the tying of the knot, you can simply cut the wall and come towards it. Again, I say, no elasticity, you will apply big force. Is it understandable? Say this half of centimeter, it is buffering zone, which will protect the wall of your sinus from the traumatization. Unfortunately, in majority of the cases, a ligation of sinuses will critically increase intracranial pressure. So we can use it only in one situation. Listen with me. Most usually damaged sinus, it is superior sagittal sinus. So if it is trauma of superior sagittal sinus in front of sulcus centralis, we can close ligate it forever. Why? Because in this level, it is not so wide and it doesn't store so much blood. More of this, there are communication between superior and inferior. If you will make ligation behind of sulcus centralis, more than in 90% of the cases, it will give them mortality. Due to the storage of big amount of the blood, this small anastomosis will not be enough to provide it from one sinus to another sinus. Intracranial pressure will be increased, and it will give all pathological mechanism, which I said before. There aren't one method which is used permanently to arrest the bleeding, temporarily, sorry, to arrest the bleeding, because all these methods is permanent methods. What can you do in street, for example? If you will see that the bone is perforated, and from cranial cavity we have flow of the blood. Usually, of course, it's happened with superior sagittal. 80% of all sinus traumas become to superior sagittal sinus due to its very big size and very superficial location. What can I do? Hold your hands like this. This is sinus. Above the sinus, we have the bone. Between sinus and bone, we have the epidural space. If from wound, I will insert it in epidural space, big amount of sterile bandages, which we call the, how we call it? Tampons. Big tampon. Finally, the foreign body will be formed here, and upper wall will be pressed to the wall. You understand or no? It is more than simple. But usually we need to use more than 7-8 meters of simple bandages, yeah? Which we use for our wounds, to make the volume. Otherwise, the pressure will not be increased and the walls will not be connected to each other. Method is great. Before hospitalization, it will save the life of the patient. After, you will do the methods which I described. You will make trephination. You will open the region. So it can save the life. in some exceptional cases, it can be used like the permanent method. If you cannot make hospitalization of the patient due to the different causes, problems of the patient, problems of the roads, problems of the hospitals, you can use it like the permanent method, but again, only for superior sagittal and only in front of the sulcus centralis. How we projected sulcus centralis by Cronley diagram I give you. Don't sleep. What you will do, in that case again, you inserted the tampons and you wait minimally 10 days. After this, you can remove the tampons. Why not before? Of course, thrombus form after hours. But during the first 7-8 days, between the thrombus and the bandage, there are junctions. Then you remove the bandage, you mechanically remove a thrombus from the lumen of the vessel. After 8, 9, 10 days, bandage is covered by the mucus. Of course, you use the antibiotic therapy to prevent formation of any infection. And it loses the connection with the thrombus. You can remove it without the formation of secondary bleedings. Is it understandable for you? Very well. Let's continue. That is the methods of the arresting of the bleeding from the dura mater venous sinus. Finally, we come to the group number 4. It is the vessels of brain. Guys, nothing not unique here. I told you how we arrest the bleeding from soft tissues. That is also soft tissues, but there are exceptions. Exception, of course, it is any printing arterial forceps. Exception, it is diathermical coagulation, electricity, which doesn't use for the brain. And you will be very careful with ligation of the magistrally vessels, because in majority of the cases, ligation of the magistrally vessels will give the necrotization, ischemical processes of the brain. That's why here we make microsurgical manipulations, for example, using the optical equipment, suturing of the vessel walls, restorization of the big vessels. Otherwise, if you will just take and ligate it, for example, internal carotid artery in one side, huge chance of formation of the same side, not reversible, ischemical processes of the brain structures. Say, microsurgical manipulation, how to make vascular sutures, I will teach you. But rule number 1, I told you many times. Vessels should be connected. Hold your hands like this. Intima to intima. Let's say then you suture 2 tips of the vessel. First of all, you must make the exvagination of the wall. Because if intima will not be touched to intima, thank you very much, you will not have the smooth surface in the place of the suture. Now hold your fingers like this. If instead of exvagination, you will have invagination in place of the suture, 100% possibility of thrombus formation in this region. So rule number 1, during the vascular sutures, intima should be smooth after the suture. You can achieve it only if intima will touch to intima. And then you will apply marginal sutures. Interrupted or non-interrupted, that is another question. Very well. We finished to speak about bleedings. That's a small review. Again, I tell you 4 sources of the bleeding, and generally 4 types of arresting of bleeding. 2 temporal, 2 permanent. Let's continue. Till now, I spoke only about step number 1 of wound treatment. I arrested the bleeding. What after? Right, please. Step number 2 of the wound treatment we call primary surgical debridement of the wound, or primary surgical treatment of the wound. Let's say my first topic, it is primary surgical treatment. I told you that stage number 1, it is arresting of the bleeding. Stage number 2, it is just primary surgical debridement. What does it mean? Finish to write, just listen. In my hand, I take dissecting forceps. In another my hand, I take the scalpel. And first what I do, after arresting of the bleeding, after cleaning of the blood, I make revision of the wound. What should I find? Everything which doesn't belong to this region, foreign bodies, ground, pieces of the knife, I don't know, anything which you can imagine. And everything which is not alive, crushed tissues, necrotizated tissues, I don't know, anything which is not alive. Pieces of the bones, which doesn't cover by periosteum, which is smaller than 1 centimeter in diameter. This is not alive for us. I must meticulously remove all these mentioned structures. If the new bleeding will be happen during this, according to the methods which I explained for you, I will arrest the bleedings. What after? After I should make the manipulation, again, we are still in stage number 2, which is called refreshing of the margins of the wounds. What is it? Unfortunately, in majority of the cases, some necrotizated structures is fused with the normal tissues, or ground it is inhibited inside of the walls, and you cannot just by dissecting forceps remove it. You can say, we can use some liquid solutions. Yeah, I will use antiseptics. This is the liquids which is kill the microorganisms like chlorhexidine or hydroxyperoxide or furacillin solutions. That's it. This is the special liquids which is working 2 directions. Direction number 1. Due to the special chemical substance, they kill the microorganism. Direction number 2, I think, is understandable. They wash and remove anything which doesn't belong to the wound. This is, by the way, from that point of the view, great is hydroxyperoxide. Why? It makes the form. And by the forming, it is remove even the some structures which can be not visible by your eye control. Okay, but sometimes even this is not enough. Because sometimes these foreign bodies, these necrotizated structures glue to the wound margins, wound walls, and you must sharply cut and remove them. Of course, you can say that during the sharp manipulation we will have more bleedings. Yes, of course. Remember the methods of arresting of the bleeding and do your best. But here you must remember about 2 important rules. Rule number 1. This method we call refreshing of the margins. But then you make refreshing, you must remember about even not 2, but even about 3 rules. Rule number 1. Don't make refreshment near a location of big vessels and nerves. Otherwise, you will have mortal bleedings. Rule number 2. Don't make refreshment near intact interfacial loose connective tissue spaces. Because by your refreshment, you will open the space and you will mechanically provide infection deep cell. Rule number 3. Don't make refreshment in the regions with non-elastic and movable skin. Because otherwise, after refreshment, connection of the margin of the wound will be or hard or impossible for you. That is 3 rules which you should remember, otherwise you will have big problems. Cause number 1, you don't know projection of big vessels, you make refreshment and damage them, or the person will die by the bleeding, or you will lose huge amount of the time to arrest it, and God knows what will be happen after. Situation 2, there are non-damaged loose connective tissue. By your refreshment, you damage it. Infection from wound pass to this space, and touch wood, if it is connected space, it will go to the vitally important regions, like the mediastinum, and again, God knows what will be happen after. Station number 3, surgeon is stupid, and for example, in front of parietal occipital region, he make refreshment up to 1 centimeter of the margin. He don't damage any big artery, he don't damage any interfacial space, but sorry, he's so far the margins of wound from each other that now without plastical reconstruction, it will be impossible to close the wound due to the special qualities of the wound here. Especially it is actual for so-called scalping wounds of frontoparieto-occipital region. What does it mean, scalp? It is abbreviation. Skin, connective tissue, aponeurosis, periosteum, loose connective. What does it mean, scalping wound? If first 3 layers of this scalp damaged together, skin, subcutaneous fatty tissue, aponeurosis, it gives huge flower shape or rose shape open wound. Can you attract your attention into this picture? Classical scalping wound. You see, so margins is gaping, from each other, go out. Why? Simply, guys, because we are 3 structures which is naturally connected to each other by dense threads, by septas. Then only me and she is damaged. 3rd layer fix our margins and don't give the chance to go far from each other. If we damage together, no any fixation is not happen, and the margins is simply go far, and we have huge form of the wounds. And if even you will try to refresh it one more, you will have awful situation. Without, for example, skin grafting material from another region, it will be impossible to be closed. Idea is understandable. Once again, manipulation number 2, it is primary surgical debridement. You remove all foreign bodies. If it is necessary, you refresh. For example, in head region, there are rules. Don't make refreshment more than 0.5 centimeter from the margins and from the floor of the wound. Of course, in the regions with more elastic skin, it can be a little bit more. In the region with less elastic skin, it should be less. Or just, it will not be performed. Right, please. Stage number 3. Let's say we arrest the bleeding. We make the primary treatment. We use antiseptic solutions to wash the teeth. Now we come to stage number 3. Right, and remember, we meticulously drain all loose connective tissue species which is involved inside of the wound. This is very important. Open the brackets and write, please. For connected spaces, we do our best to decrease or close communication with lower located compartments of this space, or by primary suturing of the walls, or by wide drainages of the space from downwards. You insert the drainages. All liquid which will be flowed to down will not continue to go to mediastinum, but will come to outside. Or you take the primary sutures and close this communication. But suturing is not so simple. You must be sure that infection doesn't go to down. Because if it goes to down and you will close it, you will stop the pus inside the space. So here you must be very careful. How many spaces is open? Samely, you will drain each one by inserting of the drainages inside the body. By the way, drainage is divided into 2 types, so-called active and passive. What does it mean? Don't write, just listen. What does it mean, active drainage? You connect the tip of the tube by sucking machine. It makes the negative pressure, so liquids from the space by this pump removed, and you achieve your goal. What does it mean, passive drainage? Due to the gradient of the pressure, inside of the inflammation, usually there are high pressure, in environment there are low pressure, you insert a tube inside of the place of accumulation of the liquid, and this liquid from inside come to outside, again, due to the difference of the pressure. How you will choose which one is better? Remember, it's simple. Usually, if the problem located inside of the cavities, you use active drainage. Why? Because inside of the cavities, inflammation will not increase so much the pressure to passively remove the liquid. Cavities is big. Vice versa, if it is problem which is located between the tissues, between the layers, in loose connectives, for example, usually passive drainage is also enough because here no any empty space, and even the small inflammation critically increase the pressure. And by the gravity forces, by the natural depth difference between the gradient of the pressure, liquid will flow from inside to outside. Let's say stage number 3, one of the most important stages, it is the drainages of all open spaces. Continue, please. Stage number 4, unfortunately we come to conclusion. Stage number 4, it is closing of the wound. It is voice simple, but in reality it is very hard. Open the brackets and write, please. There are several types of the closing of the wound. First one, it is just primary closing of the wound, bluntly, by complete suture. Completely you suture the wound, layer by layer, as I teach you, and you close its communication with the environment. You close it, you suture. Open the brackets and write, please. That method is used only for non-infected type of the wounds. Otherwise, if it is infected, I don't speak about putreficated, but even if it is just infected, you don't see pus in the time of your wound. But you will sure that if there are infections, this pus will be happen. And if you just bluntly close it, the pus will go to inside. Idea is understanding of it. By the way, which wounds for us is non-infected? Which wound is non-infected? Question is simple. I say wounds is divided into infected and non-infected. Non-infected we can suture completely and disconnect it from our environment. Which wounds we call non-infected? Oh, you think that during my investigation I will make the microbiological test to understand does it contain the microbes or not? It is stupid. Remember, please, only one type of the wound for us is called non-infected. It is surgical. You understand me? If you make surgery, you cut the tissues in sterile conditions, such kind of the wound for us is sterile, non-infected. All another wounds, doesn't matter, biting, cutting, piercing, crushing, it is inflamed for us because even in the air there are huge amount of the microorganisms. I don't speak about ground, I don't speak about foreign bodies and something else. Let's say right, please, type number 2 of the closing of the wound. It is closing of the wound up to the drainages. Let's say drainages from the wound removed to outside. And we make sutures up to these rubber tubes or up to these drainages. Wound doesn't close bluntly. Inside of it, we inserted special drainage materials. Is it understandable for you? Type number 3, write please. It is applying of the secondary sutures. They decrease the size of the wound approximately twice, but doesn't finally connect it margins to each other. In the brackets, right, in case of the big necrotizated surfaces of the wound, for example, gangrene. If I will close even by the drainage, this drainage will not be enough to remove big amount of the necrotizated structure. I will, by dissecting forceps during several days, weeks, clean this wound. I little bit decrease the size of it who don't have in the future huge scar, but they don't connect the margins to each other. Otherwise, the person will be dying by the intoxication. And finally, last, third, fourth way, it is treatment of the wound without suture, in open way. This is critically important in the treatment, for example, of anaerobical infectional gangrenes. We must have wide passage of the oxygen inside of the wound, and there are the big necrotizated regions. Otherwise, again, the person will be dead. You see, guys, from all surgeries, I explain only topic number 1 and 2, yeah, arresting of the bleeding and the treatment of the wounds. That's all, but because material is very big, huge, what can I say? I'll wait 2 minutes, I will check your attendance. Sit down.